Everyone, my name's Christine McCartney. I'm the Director of the National Centre for Immunisation Research and Surveillance. And first and foremost, I'd like to very much acknowledge the traditional owners of the land on which we're meeting today, the Darug people, and pay my considerable respects to their elders, past, present and future, and indeed to Aboriginal people who are here today in the audience with us and joining us across all the beautiful Aboriginal Torres Strait Islander lands of Australia. So we are, this is our third, I think, seminar series for the year, and we're incredibly lucky to have another fantastic overseas speaker with us, as well as our own Nick Wood. So it's my considerable pleasure to introduce Assistant Professor Deshane Fell. Deshane is an academic at the University of Ottawa in Canada, and she's a perinatal epidemiologist who's got a strong interest in outcomes of pregnancy and birth, and has done a lot of work around immunisation. So I've just completely botched her bio, but she's going to forgive me for that because I had the pleasure of meeting Deshane at a conference in Vietnam last year where we shared some lovely Vietnamese food and time together in Hanoi. So it's a great pleasure to welcome her to join us in Sydney. And I'll hand over to you now, Deshane, to give us your presentation. Thank you. Now, sorry, I didn't even give the title of your presentation, but I know you're going to do that.
I can do that. Thank you. Good morning, and thank you for the introduction. And I'd also like to thank, in addition to NCIRS, my colleague Annette Regan, Dr. Annette Regan in Western Australia at Curtin University, who brought me to Australia. So I'm spending 3 weeks here touring around. I've just spent a week in Perth, and now I'm here, and then I'll be heading to Adelaide for a week as well. So it's really my pleasure to be here. You can see the title of my talk is a Maternal Immunization, Current Status and Future Direction. So I'm going to sort of set the stage from a high level as far as maternal immunization is concerned, and then I'll hand it over to Dr. Wood, who's going to speak more about the Australian context. I thought before I got started, I would show you what winter really looks like. This is fall for me, the temperature's here. In the top left is what it looks like in Ottawa. This is where I currently live. And you can see the Rideau Canal, which freezes over every winter, and we get to go on a nice long 7-kilometer skate, which is lovely. And that's our parliament actually in the background there on the left. And then in the bottom photograph, Revelstoke, British Columbia is where I grew up. It's the land of huge snow and backcountry skiing. And I think there are a lot of Australians there actually who chase the winter. So this is just an outline of my talk. I'll just begin very briefly with some background and rationale for immunization during pregnancy. I'll tell you a little bit about the vaccines that we currently recommend for pregnant women, and then talk about the new vaccines that are currently under development now for future implementation in the obstetrical population. And then from a very high level, just mention a few issues related to safety monitoring of pregnant women. So as you know, pregnant women go through quite dramatic physical, physiological, and immunological changes throughout their pregnancy, which is really a relatively short period of time. And this is thought to at least explain in part some of the increased susceptibility that they have to certain pathogens, as well as increased severity of clinical disease that they have also following infection with certain pathogens. And of course, we also know that the fetus is vulnerable to maternal infection as well. It's one of many pathways to some adverse birth outcomes, including things like congenital anomalies, as well as spontaneous abortion. And then finally, we all know that infants also bear a very high burden when we think of morbidity and mortality from infection. These figures are from a global burden of disease study. And what you can see on the left-hand side, and I've summarized below, is that infectious causes of neonatal mortality, just the causes that I've listed there, and there are certainly more, account for about 1/4 of all deaths in the first 28 days of life. And on the right-hand plot is from 28 days to 365 days, so post-neonatal mortality. And again, infection plays a major role in mortality in that time period. So the reason then that we immunize pregnant women is, first of all, to protect pregnant women themselves from infection. The second reason is to reduce transfer of pathogens and infection to the fetus and to the newborn. And then the third reason, which I think is really behind the huge momentum and research and development right now in maternal immunization, is because maternal immunization can confer passive immunity to the neonate for several months, which is covering them through a period of vulnerability, which you'll see here. So on the left-hand side of this figure, you'll see in the absence of maternal immunization, of course, there are maternal antibodies that cross the placental barrier, and the infant is born with a certain amount of maternal antibody. But there's a gap between the waning of those antibodies and when they themselves begin to develop their own immunity through vaccination or through infection. And that the length of that window of vulnerability, of course, differs according to the type of pathogen that we're talking about. So in the case of influenza, for instance, we don't vaccinate infants until they're 6 months of age. So that's quite a long window. Of course, the window is shorter for other diseases such as pertussis. So you can see on the right-hand side, if we boost the level of maternal antibodies, hopefully above some protective level, the infants are born with a higher concentration of maternal antibodies, which narrows that time period of vulnerability before they start to develop their own active immunity. So let's talk a little bit about what we currently recommend for immunization during pregnancy. Right now, and I think these recommendations here are actually derived primarily from the United States and Canada, but I think they're quite similar here, at least as far as the vaccines, perhaps not the timing. But currently, we recommend inactivated influenza vaccination in each pregnancy for pregnant women. In Canada, we recommend that for any trimester of pregnancy. I'm not sure what the recommendation is here in Australia. It's the same. It's also the same in the United States and many other countries. Of course, we also recommend now Tdap in pregnancy, and this is a brand new recommendation in Canada, but I know it's been in place for several years here in Australia and even longer in other countries, and I'll speak about that a bit more later, but this is a more recent recommendation globally. And then tetanus as well for countries that are still in the process of eliminating maternal neonatal tetanus. And of course, the MNT elimination initiative is really probably the first successful demonstration of maternal immunization as a strategy for preventing neonatal disease and mortality. And the MNT initiative includes immunization of pregnant women and women of reproductive age. And in addition to other components of that initiative, has resulted in a dramatic reduction in neonatal tetanus deaths globally. You can see here the countries in gray that had already eliminated MNT prior to 2000. In green are shown the countries that eliminated maternal neonatal tetanus between 2000 and 2015. And then in red, the countries where MNT is still a problem and where active tetanus immunization programs are still ongoing. This is slightly out of date. This is from 2015, but I just recently read an article that said that up to about a year ago, June 2017, there were now 16 countries that still hadn't eliminated MNT. So that has gone down a little bit more compared to 2015. So that's good. Influenza, of course, I think is what we probably all think of when we think of maternal immunization, most prominently because it's a recommendation that's been in place for quite a long time. And I think we all know that pregnant women are considered a high-risk group for influenza disease, and in particular pandemic influenza. And these case series papers that you see here are from the United States from 100 years ago. So we're celebrating, if you will, the 100th anniversary now of the 2018-19 Spanish influenza pandemic. And so in each of these case series from the United States, women who were infected with pandemic influenza had high rates of mortality as well as pregnancy loss. But we also know that seasonal influenza is also an issue, although not as dramatically as pandemic influenza, certainly. This is from a study that I was involved in. In fact, this was really my entry into infection and vaccination in pregnancy a number of years ago. We conducted this study in Nova Scotia. This was with Noni MacDonald, who I know some of you know, and Shelley McNeil. And we looked at risk of hospitalization for influenza or influenza-related morbidity in pregnant women comparing to themselves the year before pregnancy. And what you can see is that the risk of hospitalization for influenza increased with each trimester relative to the year before pregnancy, particularly in high-risk women. So we define high-risk women as those who had pre-existing comorbid conditions such as asthma, hypertension, cardiac disease, that theoretically would place them at a higher risk for influenza morbidity. And in fact, our guidelines for immunization against influenza in Canada used to be a high-risk strategy of those women only prior to 2007, I believe it was, and then we expanded to a universal strategy. But what you'll see is that even in low-risk women, so women without those conditions before pregnancy, there's still an elevated risk from seasonal influenza. So I'm not going to say too much more about influenza because I want to spend more time on pertussis and on the new vaccines. One thing that's quite interesting, if you look at the inset in the bottom right, you'll see the number of countries in 2006 that had a policy that either targeted pregnant women specifically for influenza vaccination, or that had a policy for adult immunization against influenza that obviously would have included pregnant women. And there were only 15. And by 2014, there were 84 countries. And again, it's probably gone up a little bit more since then. But a lot of this change really happened in and just after the 2009 H1N1 pandemic, which was a time period when pregnant women were certainly a very high concern for disease, for severe disease. And also, a lot of countries at that point were able to collect additional information on vaccination and pregnancy for the first time. So we have much more evidence now on vaccination and pregnancy post-pandemic than we did before. We also have beautiful data on the efficacy of vaccinating pregnant women in terms of preventing not only lab-confirmed influenza in pregnant women themselves, but also in their infants. There are now 4 randomized controlled trials, 3 of which are quite recent. They were funded by the Bill and Melinda Gates Foundation. And you can see in the bottom right-hand plot, just looking at the VE, the vaccine efficacy estimates in the infants ranged from 30% up to about 63% in the Bangladesh study. So this very nicely demonstrated the effectiveness. This is over a 6-month follow-up period for the infants. And I think, again, has further given momentum to the interest in maternal immunization as a strategy for preventing neonatal disease. As far as what we know about safety, I think we can say that we know quite a lot about safety now. These are 3 systematic reviews that have been published. There are several others that have also been published. None of the studies looking at various different pregnancy outcomes have found any evidence that there's any adverse effects of immunization during pregnancy in terms of outcomes such as preterm birth or fetal death, congenital anomalies, for instance. The one exception to that I will say, only because you may have heard about this one study that had quite a lot of press last fall, North American fall, was a study from the United States that did find, it was a small case control study, and did find an increased risk of spontaneous abortion following vaccination in the first trimester, but it was a very small study, had very wide confidence intervals, and was mostly limited to women who'd received vaccine in 2 consecutive years. So this is still an area that really needs to be pursued in future research, and I think the CDC is following up on this now. So let's move on to pertussis. As you know, pertussis is a bacterial infection that can cause quite severe disease as well as death, and most of that burden is really experienced by very young infants. And not so long ago, in about 2012, there were epidemics of pertussis seen in the United Kingdom and the United States and other regions of the world as well. And because of this, and I imagine really building on the success of the maternal influenza immunization strategy and long-term success of tetanus immunization in pregnancy, the United States and the UK rapidly implemented recommendations for universal Tdap administration in pregnancy to prevent neonatal disease. And many countries have since followed suit over the past 6 or 7 years. You can see the shaded countries here on the global map showing the countries with a policy. In addition, Singapore implemented a policy in November. Canada just followed in February of this year, so we were a little bit slow compared with other countries, including Australia. And you can see this is just a closer view of the European countries. So quite a few countries now recommend universal Tdap administration in each pregnancy. Again, there's a lot more data coming now following the implementation of these recommendations about effectiveness. There are actually a couple of other effectiveness studies that I haven't listed here, but these are, I think, some of the really seminal ones. And really, the important thing to note, I think, is that the vaccine effectiveness estimates, the VE estimates, are actually all very high, mostly in the range of about 90% within the first 2 to 3 months, perhaps a little bit lower in later time periods, and certainly high VE against the most severe pertussis, so hospitalized pertussis cases. Similarly, the safety studies have so far been favorable. There are a couple of systematic reviews. They're now a few years old and probably need to be updated. One of them, the bottom one, led by Mark McMillan. This is actually Dr. Helen Marshall's group in Adelaide, and I was part of that review. And in both cases, each of these reviews found no evidence of adverse birth outcomes in the short term or neonatal outcomes. Again, the caveat or the exception is there are now 3 of 4 studies that I'm aware of that have looked at chorioamnionitis and found a small increased risk, and 1 study that has also found an increased risk of postpartum hemorrhage. These both really need follow-up studies. The obstetricians I've spoken with are really not convinced that it makes biological sense, that perhaps it's a chance finding. I think chorioamnionitis is often not well coded in the types of large databases that are actually being used for these studies. So I think this is an ongoing area of research. This is quite a recent study from the US, the Vaccine Safety Data Link. This was published just in 2017 in Vaccine, and I just wanted to show some of the other outcomes that in the neonatal period that they've been looking at. Again, you do see the increased relative risk of chorioamnionitis, but besides that, all of the other outcomes have been null. So for neonatal sepsis, pneumonia, RDS, convulsions in the newborn period. So this is very good, and I would say this is probably the most robust study that we have so far. It was a huge study. The one issue that is still under investigation and really does require more research is the issue of blunting. So there have been a number of studies now that have found that the increased maternal antibodies in the infants blunts the infant's own immune response to their primary series. A couple of small clinical trials, one from the United States and one from Vietnam, found that by the time of the 12-month booster dose, that the difference between infants born to immunized mothers and non-immunized mothers had resolved. But there's actually another study that is in press now with clinical infectious diseases. It's Scott Halperin's work from Canada, and they did not find that. So the clinical relevance is still unclear, and this requires further assessment. The one thing I will say is there are now 2 observational studies very recently that have looked at the clinical impact of maternal Tdap immunization beyond the time period of the first dose and actually found significant VE in later time periods. So I'll just show you, I have tables from both of those papers so you can see this is the study from the United Kingdom. And the VE after the first dose of the infant series was 82%. 69% after 2 doses, and then in this study, no longer significant after the 3rd dose. But in the American study, a little bit different. This was just published, this is out of California. And again, about 90% after the first dose and 90% in that early time window, 80% after the first dose. Not significant after the second dose, but the number of cases was very small. And then about 66% after 3 doses. So that's reassuring, I think, that perhaps the clinical impact of the blunting that we're seeing won't have an impact on disease. Okay, so I wanted to talk a little bit about the new vaccines, and I probably have to keep an eye on time if someone wants to tell me if I'm okay. So there are 2 vaccines that are currently under quite intense research and development for future implementation in pregnant women. The vaccine that's furthest, most advanced in its development is the vaccine for respiratory syncytial virus, or RSV, which, as you know, is a very common cause of acute lower respiratory infection around the world. And primary infection is actually extremely common with most infants. Most infants will have been infected by the age of 2, so it's very common. In young infants, clinically, RSV presents as pneumonia and bronchiolitis, but it's also a risk factor for later poor respiratory outcomes, including early wheeze and asthma, although there's a little bit of controversy about how strong that association is. It's very difficult to study. This is a screenshot from the PATH website, PATH in Seattle, just showing the research and development of all different products for RSV that are in the pipeline, as it were. So not only vaccines, but also monoclonal antibodies that are in development currently. The one that's circled to the far right is a vaccine that I will tell you about a little bit more. So this is the leading candidate. It's currently in a phase 3 trial. There are several sites in Australia. I don't know if anyone in the room is involved. There are other people. I know there's a site in Adelaide, I believe, and in Perth, and maybe here as well. If you go to the clinicaltrials.gov website, you can get a little bit more information, although there's not a lot, but basically this is a phase 3 international study. It's placebo-controlled, and the primary outcome is prevention of RSV, lower respiratory tract infection, up to 90 days in the infants. And originally, I think the plan was to be recruiting women up to 2020. But if you go to the Novavax website, so Novavax is the developer of this particular vaccine product, you'll see that things are going well and they're progressing even faster than initially expected. This slide is just showing you the number of countries that are involved in recruiting pregnant women for this trial. So recently, just in December actually, so a few months ago, they did what they called an informational analysis. So not an interim analysis, but to look at, I guess, whether it was feasible to continue with the trial. And they had targeted a minimum efficacy threshold against the primary outcome of RSV LRTI of 40%. And all they're saying is that it's somewhere between 45 and 100%. So it's higher than the minimum level that they wanted, which is good. And so they're continuing with the trial. And in fact, I think the process is even accelerating a little bit. This is their timeline. And you can see that they are hoping to have their interim analysis completed in 2019 and possibly file for licensure in 2020. So it's possible that we'll even have a product for pregnancy for pregnant women in 2020, which is not that far off. Oh, sorry, yes. Okay, so the top few bullets here about the clinical trials, this is actually a little bit old. This is before I saw the press release from Novavax, but certainly the phase 1 and phase 2 studies also were very favorable. The vaccine was well tolerated in pregnant women. And of course, now we see that they're finding it also is efficacious in the ongoing phase 3 trial, and it's in accelerated development. There are, of course, a number of challenges, not least of which that there are probably or maybe different vaccines required for different target populations. So this is pregnant women, but of course, we're also very concerned about infants. We know that passive immunity from the maternal antibodies will only last for a short period of time, probably the first 3 or 4 months or so. So there may be a pediatric vaccination that's required. Of course, there are other target populations as well, including the elderly. And one area of ongoing discussion and research is looking at what would be required, what's the optimal study design to really look at the ability of this vaccine to impact later pediatric respiratory outcomes such as wheeze and asthma. So I think the WHO has an RFP out right now to look at and make recommendations for optimal study designs, because this would be very difficult to assess in a clinical trial. Okay, I'll just move forward to the next vaccine, which is a vaccine being developed for Group B streptococcal disease, or GBS. This is a bacterium that is commonly colonizes the gastrointestinal tract, perhaps in up to 35% of pregnant women who are screened. There are 10 serotypes. 5 of them account for 85 to 90% of invasive GBS disease in infants. And these are obviously the target of vaccine development. And most of the research that I've seen is on a trivalent GBS candidate, which is for serotypes 1A, 1B, and 3, which you can see make up the largest parts of that pie. There are really 2 clinical syndromes that we're concerned about when we think of GBS disease in infants. The first is an early onset disease, which is a mother to infant transmission, usually during the birth itself. And this is a common cause of early onset neonatal sepsis, as well as pneumonia and meningitis. But then there's this separate clinical syndrome, which is called late onset disease that develops at after the first week of life. And this is more commonly acquired through hospital or community exposure. And what's interesting about these 2 syndromes is what's happened to them over time with the strategy that we currently have for prevention. So right now in probably most high-income countries, we do routine screening of pregnant women at 35 to 37 weeks. In some countries, that's all pregnant women, as it is in Canada. In other countries, it's sometimes a risk-based approach where just women who have certain risk factors are screened. In late pregnancy, so close to the time of the expected delivery at term, if they screen positive, then they're administered antibiotics just prior to labor to prevent transmission to the infant. But obviously this is very difficult to implement in low resource settings, so it really hasn't been implemented outside of high income settings. But what's also interesting in the plot, as you can see, this is from the American College of Obstetrics and Gynecologists. You can see in the solid blue line is the incidence of early onset GBS disease in infants, and you can see that since the implementation of the screening and prophylaxis approach, the rate has really gone down dramatically. But in the dashed line across the bottom is our incidence rates for late onset disease, and these really haven't budged at all in relation to this strategy. So the hope is that if we had a vaccine that we could administer a little bit earlier in the pregnancy, and that would have longer lasting impact, then hopefully we would see not only a reduction in early onset disease, but also late onset disease, but also other potential benefits such as the ability to possibly prevent some GBS attributable stillbirth events, and possibly even preterm birth. There may be some association with preterm birth. And also, of course, the preterm infants are most at risk of GBS disease in the neonatal period. And right now they completely don't benefit from the screening and IAP protocol that we have, because the screening is done too late. So just briefly, the leading vaccine candidate is a conjugated capsular polysaccharide vaccine. Again, most of the research that I've seen has been on a trivalent GBS vaccine. There have been phase 1 and phase 2 trials only so far in more than 600 non-pregnant women, but also more than 500 pregnant women in 4 countries, I think most or all of them in Africa. And so far it seems that it's been well tolerated and is resulting in it's getting favorable antibody responses in pregnant women. But there are many challenges with this vaccine, probably more than with RSV. For one thing, we would require very large sample sizes in a phase 3 trial if you wanted to actually look at invasive disease. And so it may be that if it reaches licensure, it may be more likely to be based on immunological outcomes. One of the other big concerns is the geographic heterogeneity in the serotype distribution, and also the concerns about serotype replacement. Okay, so just a few words about safety monitoring, and then I'll hand it over to Dr. Wood. As you know, we tend to, we know that the randomized controlled trial with placebo control can really give us the highest quality evidence about any intervention, including vaccination. And there are many advantages, of course, of RCTs, but there are also a number of disadvantages that can include the fact that they're often, not always, often quite small. You might be limited to the number of outcomes you can assess. Looking at longer term outcomes is difficult and sometimes not practical at all. Just to take the example of the existing RCTs that we do have for influenza immunization in pregnant women, they're excellent trials, but of course they are relatively small, which makes it difficult to look at rare pregnancy outcomes if you're thinking of safety, which is sort of my area of research. It's restricted to healthy pregnant women in the 2nd and 3rd trimester, so you can't look at things like congenital anomalies, for instance, or any other 1st trimester adverse events. And the follow-up was restricted to 6 months of age, so again, you don't have that long-term perspective on different outcomes in the pediatric population. So as a result of that, observational studies have really filled the space in terms of looking at not only safety, but also effectiveness. And this is also true for Tdap in pregnancy. In fact, there really aren't any trials of Tdap in pregnancy that are large enough to look at any sort of pregnancy outcomes. And so observational studies have played a major role. But of course, any of you who are epidemiologists in the room will know that there are many inherent problems with observational studies. Just a few are listed here. But one of the other interesting things that I think plagues both RCTs potentially and also observational studies is a lack of consistency in a lot of the definitions. So I'm talking about pregnancy outcomes specifically here, as well as ascertainment of those outcomes. And this makes it very difficult to evaluate the quality of the evidence that we have and to do systematic reviews and meta-analyses, which are very important in this area. So just to conclude, I'll tell you about the Brighton collaboration, the Global Alignment of Immunization Safety Assessment. This is a project that, again, has been supported by the Bill and Melinda Gates Foundation, and they've done a lot of work to try and recommend standardization of definitions of adverse events following immunization in pregnancy. And they've actually published in 2 issues dedicated to these definitions so far in Vaccine, one published in 2016 and the other just last year. And so hopefully these will be more widely implemented now, not only in trials, but also in observational studies going forward, which would certainly make assessing the evidence a little bit easier. I think there are a number of future directions. There are many, of course, many evidence gaps still clinically with all of the vaccines I've spoken about, but from my perspective, thinking of pregnancy outcomes, one thing that's incredibly important and that we don't have a lot of data on around the world are background rates of adverse pregnancy outcomes. That's obviously really important when you're implementing a new population-wide intervention in pregnant women. So I think in settings like Australia, Canada, the United States, many high-income settings, we're fortunate to have robust databases, perinatal databases, and surveillance systems that can give us that information, but that's certainly not the case in many other settings. We have we have pretty poor data really for studying miscarriage and stillbirth. I'll just say it that way. It's very difficult to collect information on miscarriage in particular, and a lot of our data systems, again, in high income settings are artificially kind of truncated to 20 weeks. So we tend to start collecting information on pregnancies that make it as far as 20 weeks. So we have this whole unobserved population. So for the vaccines that we administer in the first trimester, it's obviously very important to still work toward improving information and data systems so that we can better assess that time period. Again, I've talked about Gaia already. We definitely have to do more work on improving our research methodologies for observational studies, especially since they are playing such an important role, and I think they'll continue to play an important role even as RSV vaccine is licensed and then implemented in pregnancy. I would say particularly in that theme, because that is a brand new vaccine, whereas influenza, Tdap, these are vaccines we've had for decades, we've been using in the whole population. We know a lot about their safety performance, but RSV, this will be this is new territory, I think, for us. And I think if I can put in one plug as well, we need better mechanisms and approaches for being able to share data nationally. In Canada, we can't even get it across our provincial borders, never mind sharing internationally. But really, this is an important direction, I think, for the future. And there is work being done in this area now to enable more sharing across countries, which would be extremely useful for looking at some of the rare outcomes that we are concerned about when we think about pregnancy. So I will conclude. I'd just like to acknowledge I was very fortunate to be able to attend a lot of excellent lectures over the past year or so on maternal immunization and drew on some of those sources. And I'd also like to say that the next International Neonatal Maternal Immunization Symposium is being held in Vancouver in September of 2019. So you can come visit Vancouver. We won't have snow like what I showed you on the first slide. Vancouver never gets snow like that, but certainly not in September. It'll be lovely. And with that, I'd like to thank you for your time.
It's an absolutely fantastic talk. I mean, we've got 100 people online now, and for those who in the room and online, I would encourage people to share Shane's talk, because it's just what a bird's eye overview, but also drilling down with so much evidence. In the sake of time, I might let Nick come up and present next, and then I'm very interested to talk about what we need to do more, particularly on your last point, Shane. So just briefly introducing Nick Wood. He's one of our own here at NCIRS, leading clinical researcher and associate professor of paediatrics with a strong interest also in maternal vaccination.
Thanks, Christine, and particularly thanks to Shane for a wonderful talk, which hopefully my talk will complement what you've done so far, which is fantastic. So, I mean, as you mentioned, what we're doing is giving a vaccine to a mother to hopefully protect the mother. Has to be safe, and then that would not have a negative impact on the fetus, and then hopefully have some effectiveness in the infant and also be safe. So what I'm going to try and talk to you about is Australian specific data, what we know about the vaccine effectiveness and safety, a little bit about the uptake and coverage, and then launch towards the second half into some of the unknowns in those 3 areas: the safety, effectiveness, and uptake. And I've looked at safety in what I call immunologic safety and in clinical safety. And I think it's an important time, and it's a really good space to be diving into the maternal vaccine, because there's lots of opportunities with what we know and more so what we don't know. So many of you in the audience will be aware that we now have Commonwealth funded both flu and pertussis vaccines for pregnancy. So I'll launch you into what we know about the current estimates of flu and pertussis vaccines in the Australian environment. Starting in 2015, this is courtesy of Ross Andrews, who led a multi-site study called FluMum. That was able to gauge at that point that in the people that participated in this study, uptake was around about the 40 to 50% mark for flu and pertussis. Other studies around the country at that time, you can see here, different sizes, different methods and different locations. Again, the uptake was somewhere between the 40 to 60% for both of those. In Western Australia, they've got more recent data, and you can see here that over time, this is courtesy of Paul Effler, both flu and pertussis have increased since 2014, and they're now sitting at about 55% flu and about 80% pertussis. And this is based on a telephone survey of about 800 women that they conduct annually. So that's a really good news story. In Victoria, complicated, but you can see flu on the left here, and it varies by availability of the flu vaccine. But as of middle of last year, uptake was around about 60% for flu in Victoria. This is based on their perinatal data. And for pertussis, again, it's increased over time. So, middle of last year, uptake's about 80%. So it's thanks to Lucinda Franklin and Stacey Rowe. And Stacey actually presented some of this data at ESPID this week. Okay, here's a success story from Sunshine Hospital in Victoria. Michelle Giles gave me this slide, and you can see here that very good uptake of above 80 for both flu and pertussis. This is in a setting where they actually have availability for the women to get the vaccine in an antenatal clinic. So that comes into my talk later on. So that's a very good news story. There's some challenges to recording the coverage. People get the vaccines, or women get the vaccines in different locations. They get it in the clinics, the GPs, the councils, possibly even in the pharmacies, community health clinics, university health services, and Aboriginal medical services. We record these in different ways. We record it in the GP software, we record it in obstetric hospital databases. One example is eMaternity. I think ultimately if we're able to link all these databases to hospitalizations and notifications, and there's a real power to look at effectiveness and safety. We do have a national whole of life register, the AIR, but it does not capture pregnancy as a field. Now there is the potential for it to be put on to AIR, but more importantly probably to put onto the GP software, where the GPs or the nurses administering it could actually choose the vaccine and then have a label which was meant that it was administered during pregnancy. And that could happen both at the GP software and also at the AIR. So there's an opportunity there, or at least to explore that opportunity. So that's what we know about coverage. So it's pretty good. It's changing, it's increasing, so it's a good news story. I'll then next take you to the safety of pertussis vaccines and highlight some of the systems that we have in place in Australia to monitor safety. We traditionally do it via a passive surveillance system, that's reports to the TGA, but there are some discrete research studies such as FluMum, which I mentioned before. There are data linkage studies, and we have an active surveillance system in Australia called AusVac Safety. I think it's probably, as Deshane's pointed out to you, there's at the moment internationally and from our Australian data, there's solid evidence to show that the vaccines are safe, at least in the perinatal period. But we do need to do this annually because the flu vaccine changes. So we can't rely on last year's data to inform this year's flu vaccine safety. This is one study that is an Australian study. This is the FluMum study, which is the data presented from 2012 to 2014. This is being updated and a new paper has just been submitted. But the bottom line was that in this particular FluMum study, there was no difference in birth weight or gestation between vaccinated and unvaccinated babies, mothers who got the flu. So the baby outcomes were good. Another study, this is Annette Reagan looking at the safety and reactogenicity of pertussis and flu vaccines during pregnancy, again an Australian study. The bottom line was that flu, DTPA, and a combination of flu and DTPA was safe when you looked at the mother and the adverse events. Only 1 to 2% of them had a medically attended illness post-vaccination. Ausvac safety. This is a collaboration with all the people listed here. Many of you know the way it works, but essentially the mother gets a text 3 days after the vaccine to ask if she had any reactions to yes or a no. If she says yes, she's asked to fill out more surveys. This has been happening annually, and the flu data for this year in just over 1,400 pregnant women up to the 20th of May, they're reporting about 5.7% are reporting any event and few injection site reactions, but not much in the way of fever or rash. So again, it's a good safety profile. So that's the safety story. In terms of effectiveness, again, I'll take you how effective we are from Australian studies and what systems we have in place to monitor the effectiveness in Australia. As I mentioned before, we want these vaccines to be both effective for the mother and for the infant. So we want them to prevent flu in the mum and the infant. We want it to prevent pertussis in the mum and the infant. But there probably will be some non-specific effects. So we can measure it by decline in notifications. Again, there are discrete research studies such as flu mum and data linkage studies. And there's an active flu surveillance system, which is called FluCan, and there's the PEDS component of that. And these two are looking at performing case control studies. So we need good evidence for effectiveness and for safety, which helps to maintain our uptake. And again, we need to do this annually for flu because it changes each year. What we'd like to see is a similar story to we're seeing in the UK. This is deaths from pertussis. The UK implemented their program. The deaths have fallen away subsequent to that. And the cases where the babies have died have been where the mother did not get the vaccine. So that's notifications of deaths in the UK. So in terms of Australian studies, this is one from Annette Reagan. This is looking at the effectiveness of the flu vaccine against mother getting the flu. And the effectiveness there was about 65%. And Deshane's shown you very nicely a lot of the systematic reviews which you can go to after this to see some more international data. This is another one which is an Australian study looking at the incidence of stillbirth, and the bottom line here was that there were lower stillbirth rates in the vaccinated women. Deshane's hinted at that study as well, and again some of the other studies. So this is a good news story. Interestingly, there are no studies published on the benefit of maternal pertussis vaccine against the mother getting pertussis. But in terms of maternal DTPA effectiveness against the infant getting pertussis, there's been one Australian study published which showed a VE of 94% against hospitalisation and a vaccine effectiveness of 69% against pertussis. This was a New South Wales case control study, 2015 and 16. So I think the bottom line is that we know that there's good evidence internationally from what Deshane has shown you about safety and effectiveness. We've got good uptake in Australia, and there are some Australian studies that are looking closely or have been published already on the safety and effectiveness. I like this picture because I always wonder what made them stop putting things on top of the car for them to finally say, yes, it's full, and then to drive off. So, but I think what I want to next in the next little bit is to show you some of the questions that we have unanswered and highlight to you how active Australian researchers are in this space. Okay, so in terms of knowledge gaps and effectiveness, I suppose the question is, can we improve our effectiveness? Can we change the maternal Tdap timing to make it work better? What about using the super flu vaccines that have been announced and used in the over 65s this year? Are they a reasonable thing to be giving to pregnant women? Would they work better? Should we change the infant primary vaccine schedule? So what's the optimal schedule for infants born to mothers who receive Tdap in pregnancy? Okay. As Deshane has shown you, the question is, does it matter with this suppression? Is it really a clinical concern? I think we would say, yes, you do need a booster in the second dose of life, and Australia does have that. But should we or could we delay the first dose of the AP vaccine to overcome this blunting? Is a 3, 5, 11 month schedule better than the 2, 4, 6 month? And there is some paper looking at this, and people will be looking at this internationally. This is a study that was presented at INMIS last year, and the anti-pertussis antibodies were certainly higher in the babies born to mothers who got the vaccine, and they, like they've said in their title, suggested that perhaps you could delay the first dose, not give it at 6 weeks, move it back a bit further. Maybe there's less immunosuppression, and then the post-primary infant responses are better. So I think it's an active question for us. What about infants born to mums who did not receive Tdap in pregnancy? We've shown you there's about 80% uptake. What about that missing 20%? Do they require anything in particular? And this is in cases where mother refused or was unable to be given the Tdap. In cases where mum's response to the Tdap was reduced, either because she had placental infection, which stopped transfer, or because mum had immunosuppressive disease, or perhaps because the infant was born prematurely. There are options for that, and one might be giving this monovalent pertussis vaccine. And to do that, we need to have the supply of it, and we need to know that it's efficacious and safe. You might say, well, is there a monovalent pertussis vaccine available? And it was just published in Lancet end of last year, a study which is by Bionet, and it's looking at the use of a monovalent AP vaccine in adolescents. And this vaccine is now licensed in Thailand as a monovalent AP only, and shown that it was both immunogenic and safe. So there is an AP vaccine available. Does that AP vaccine, or could it work in pregnant women? A nice paper from Todd Merkel's group in the US, where they challenged poor old infant baboons to the actual real pertussis. They blew pertussis into the baby baboon and then saw who got pertussis and who didn't. And these were baby baboons that were born to mums who'd had monovalent AP or who had not. And the bottom line was that the babies born to the mums who got the AP vaccine alone were protected compared to those where the mum didn't. So it suggests that the AP vaccine could potentially be an option. There have been some AP at birth studies which have been done around the world. One that Peter McIntyre led, where he looked at the immune responses. This is pertussis antibody levels in babies that got the AP at birth, and there were higher levels at 10 weeks of age compared to ones that didn't get it. So there's potential there that maybe an AP vaccine could be useful. Maybe mums are asking, why do I need the D and the T? Can't I just have the AP only? In terms of vaccine effectiveness, I say there's data about to be born. Ross Andrews is working on the Flu Mum paper, which will report on effectiveness for flu in mums and babies. And next week at the PHA, Jocelyn McRae and Helen will present on the maternal effectiveness of flu and pertussis for the infant. Just racing ahead, in terms of uptake and coverage, the question is, can we improve our uptake for particular groups in our community, and how best to frame the messaging for these mothers? So in terms of things that you need to do to get the mum to have a vaccine, they've got to be the right information for the woman, the right information for the provider, a prompt for recommendation, and availability of the vaccine. If you've got all of those four things, I think you'll get the vaccine. However, there's disparity between what's recommended and uptake, and we know that from several Australian studies. A nice study in Victoria, which looked at uptake by the size of the hospital, and you can see there's wide scattering, and also by the type of hospital it was. Private hospitals, and some of these were low uptake. This was high public hospitals, high level 6s, good uptake, but not. So there's a variability across the state. So that's something we need to look into. What's the best way to deliver these vaccines? This study showed that if you're overseas born or Indigenous, or that the mum was a smoker, they had low uptake compared to being a prime-ep, a rural resident, or having GP-led antenatal care. There are many Australian vaccine uptake research studies, and I've just listed them all here. Our own Sammy Carlson is working on a study which is funded by the NHMRC PEDS Partnership Grant, and that's looking at the impact, or the early infant pertussis and flu, and seeing ways at which we can think about why that mum did or did not get the vaccine. So there is certainly a lot of active Australian researchers looking at the uptake question. One example is Margie Danchin and another group looking at what's called the Mum Bub Vax study. and they're looking at the practice level, provider level, and the parent level components. And then finally, I just wanted to touch on safety knowledge gaps. I think our first real aim is to do no harm, particularly in a pregnant woman, but particularly with any vaccine, because with a pregnant woman, you're actually vaccinating two, mum and the fetus, okay? And so immunologic and clinical safety are very important. And I think if we can reassure mums that it's safe, then we can hopefully have good impact on uptake and coverage. No longer is it sufficient just to measure the antibody, okay? That's old news, all right? It's much more complicated than just antibody levels. There's now a new thing known as systems immunology, where the computers and the bioinformatics get involved, and this looks at a whole biomarker spectrum, okay? Antibodies are old news. Beyond the perinatal period, we've looked at and we presented to you today data which looks at what happens to the rates of stillbirth, what happens to the preterm deliveries, etc. But what we don't really know is what happens to that child later on. We know that influenza infection, the actual infection in pregnancy, has been linked with neuropsychiatric disorders like autism and schizophrenia. But what we really need to show is, can that vaccine be protective against these things? Okay. T-cell responses are moderated or modified in a pregnant woman when she gets a vaccine. What does that do to the child's development of atopy? So these are things that we need to look at beyond that perinatal period. Again, about to be born safety studies in the mother and the infant. There's Flu Mum, Annette Reagan's work in Western Australia, other people around the country looking at the safety, both immunological and clinical, and a large group of Australian experts looking at data linkage studies, and their names are there. So I think we're in a good position. Okay, so finally, the road ahead. Increasing uptake, I've shown you that, but it is not universal and is variable. There's a solid evidence base. We have to think about our systems to monitor it and the long-term follow-up. Australian data on the effectiveness will be born soon, and it does need to be effective, but we haven't really drilled down to what about our Indigenous population, what about infants born to mothers who are on biologic immune suppressants, that sort of things. We need to think about how best we communicate this data and what can we do better to monitor our coverage. So that's it from me, so thank you.
Okay, well, another fantastic talk, and I just wish we had had a bit longer for both. Nick, thank you so much, and Deshane as well. I mean, I think it's been an incredible overview. I'm really struck by your last point, Deshane, and this is that, you know, we've presented here on two vaccines against two diseases where we've been using those vaccines in our population for a long time. Broadly speaking, we know them well. As we move into thinking about new vaccination strategies for pregnancy, it's the imperative to get our ability to study these vaccines not only in the pre-licensure phase, but in the post-licensure implementation phase is absolutely critical. Did you want to add a little bit more on that? Because I mean, I know, you know, in Australia we are getting, the wheels are turning more on getting linked data to start to work for us. But I would just probably like to hear, you know, your thoughts a bit more on that.
Sure, I think that's a great question. I mean, I think it just leads to more questions for me, to be honest. I don't think I have a good answer, because one of the things I think we may see is that it might be implemented in low resource settings faster than in countries like Australia and Canada. I don't know. It's conjecture, but I feel like it will take a while before a new vaccine like that could be implemented in a place like Canada. And so in many of those countries, they probably don't have the types of safety surveillance systems that Dr. Wood was just speaking about. So that is certainly an issue. And I would say even in Canada, I'm not sure that we have a system that is real time enough that would really pick up something very quickly. So we also rely a lot on database linkages. We're often several years behind, though, with the data we're working on. And so, I mean, I think there probably should be more advocacy for getting more real-time surveillance systems in places that don't have them. And I mean, I think the United States is in a good position, but I think in Canada we could do some more work on that. But I'm not really sure what the answer is for settings where the largest burden is, and perhaps where the vaccines will be introduced first, potentially, how that will be monitored. Any idea?
Okay, well, look, I think, and you make a very good point, because I think it is not just, it's how, as a global community, we can support the introduction of these vaccines with data from different countries. But so questions from the audience here. Have you been overwhelmed by the incredible quality of data, Jean?
I'm Jean. I'm a pediatrician background here at NCIRS, but I was interested in the RSV vaccines. I guess there's always been a history of the initial RSV vaccine being associated with actually increasing the risk of severity of illness and causing deaths. I'm not sure if you're able to answer this, but what about these new vaccines has been done differently that they're having such good outcomes?
So that's a very good question, and I'm not a vaccinologist, so I won't be able to really contrast the components or how these vaccines were built. I know this one is very different than the other one. Of course, that is definitely still, though, a concern that people, are watching for. I guess really all I know at this point is that from the earlier phase 1 and phase 2 studies, as well as the animal studies, there has been no evidence of enhanced RSV disease in any of those studies. And obviously, I mean, I think from the informational analysis that was just done in the phase 3 trial, obviously if there were any signals of safety concerns, I'm sure we would have heard about it, and we haven't. So it looks like they're not seeing that as a concern. Yeah. So, but I don't know. Sure.
Yeah, I mean, I think they're incredibly different vaccines too. So, the vaccine in the 70s, or was a formalin activated whole virus, I think was my understanding. But if someone's out there can tell us that I'm wrong in that. But this is a complete, this is the pre-fusion protein that has been engineered. So it's a completely different type of vaccine, which is great, but incredibly important within the clinical development program for every RSV vaccine to consider this. So. Any more questions from the audience? Someone want to throw a curly one to Nick? Here we go. Jocelyn.
Hello, thank you very much. They were really great talks. My name is Jocelyn. I'm doing a PhD on maternal vaccine effectiveness. I do have a question regarding your first project where you looked at high-risk women compared to other women, and I'm just wondering, was there a difference, or did you study vaccine effectiveness in the high-risk women at all?
A little dance at the microphone here.
To be honest, that project was just looking at disease burden, if you will, or risk of influenza disease. It wasn't a vaccine study at all. So I haven't myself done any studies looking at VE in high risk and low risk women with those conditions. And off the top of my head, I can't think of any that have, other than to say that one of the RCTs that was conducted was in South Africa, and they had a cohort of non-HIV infected women and a cohort of HIV infected women. And they did find, I think they did still find, that it was effective or efficacious in those women, but to a lesser extent than in the non-HIV infected women. But beyond that, I'm not aware of other studies that have looked at that.
I think that's a really important point, though, because I think we're bringing the obstetric and midwifery community. We're really coming together as a community with our approach here. But some early anecdotes that I had received were around the fact that high-risk women were being encouraged not to get the vaccine because they're high risk at base, and then the vaccine might be worse. Whereas, that data just is so compelling with respect to the increased risk for adverse outcomes from the disease that high-risk women face. And I'm just trying to think, Nick, are you aware of any data on coverage in high-risk women with high-risk pregnancies versus not?
No, I think that's a gap, and probably the safety in the high risk versus the low risk is also a gap. So, you're trading off the safety profile with the effectiveness. We need to look at, that's why I was getting down to the subgroup research.
Okay, do we have any more final questions from the audience here? I'm sorry to our 100 participants online that we can't yet take questions remotely, but as our technology gets better and better, that'll be the case. Any final questions? All right, well, look, just in the interest of time, I think I will wrap up, but I would say that we're incredibly lucky to have Deshane also presenting on the power of working with linked data and many other things, I think, at the National Immunisation Conference next week, which is fantastic. in the Thursday afternoon session. And as Nick so kindly alluded to, many of the groups who are very active in Australia will be presenting hot new data at that conference. So I would just like to conclude by thanking both of our speakers today for absolutely fantastic presentations, and really very, very grateful that you've been able to share such high quality information with us today. Thank you.